Okay, so Sukanya, we wait for a minute and then we start.
Sure, all right.
Okay, so I'm going to start this. So let me welcome um, all the speakers and all the participants of this webinar on how should the global South act on antimicrobial resistance. I'm Amit Khurana, and I lead the program on sustainable food systems at the Center for Science and Environment, New Delhi. Center for Science and Environment is a public health research and advocacy organization, and we work on issues related to sustainability and development in India and in the areas of in global South. Um, so we know why we are here, but let me just also briefly share my perspective. So we all know that the crisis of antimicrobial resistance will disproportionately impact global South countries. We also know that our situation is different, our challenges are different, and we also know that our solutions will have to be different. There clearly are some of the best practices that are emerging, which people need to know, which different countries within the global South need to know. And CSE has been working on these issues for animal and environmental dimensions of AMR particularly for over a decade and a half now. We have been working in India with states in India. We've been working in countries in the African region, at the Asia level also. So we have some understanding, and we, in a way, also have been taking those issues at the global for the better for to inform the global South global policy and the global guidance on these issues. This webinar is an attempt to create awareness on such issues. And we all know this is World and AMR Awareness Week. And I'm quite happy to inform that CSE is celebrating or observing its 10th such campaign. And this year our campaign title is Global South Action on AMR, and it is primarily focused on social media. And you would have noted by now that my colleagues and from the media team as well as from the team in CSE have been putting out a lot of information, a lot of polls, a lot of fact cards, quote cards. We're doing a lot of stuff on the social media, and some of you, of course, would have seen that. So I would encourage my colleague to also share the link on the chat box. Um, let me now introduce the speakers and also let everyone know the structure of this discussion. So I have with me my colleague Rajeshwari Sinha. Rajeshwari is a senior program manager at the Center for Science and Environment. We work very closely on the issue of AMR. Rajeshwari will be talking about. Uh, she'll be sharing with us the key recommendations that emerged from one of the very important meetings that we did in September this year to inform the revision of the Global Action Plan on AMR. This meeting had about 100 experts from 20 countries in Africa and Asia. And Rajeshri will talk about that. And that in a way, will sum up the objective number one of this discussion. Objective number two of this discussion is essentially about creating awareness on the global section, on the action that is needed in the Global South, or the action that is being taken already in the Global South. And for that, we'll have a panel discussion, which will run for about 60 minutes, if time permits, wherein we have five speakers, very eminent speakers from different parts of the Global South, and we also have a colleague from Geneva. Uh, so let me just share the structure of that panel discussion also right away. So we'll have Evelyn Vesangula, who is the senior AMR control specialist in the One Health sector. Uh, and she's from East, Central, and Southern African Health Community, Tanzania. And we'll hear from Evelyn on the importance of regional and local uh, governance and sustainable financing. Then we'll move to Kate Medlicott, who is the team lead sanitation and wastewater, World Health Organization. Uh, we hope to hear from Kate about how WASH can be mainstreamed in containing AMR and its advantages from the perspective of Global South. Then we will hear from Dr. Vandana Roy. Dr. Roy is director and professor and head of Department of Pharmacology, Maulana Azad Medical College and Associated Hospitals. This is a New Delhi-based hospital. And we would hear from her about what needs to be done in the Global South countries like India, for example, to improve access to effective new and existing antimicrobials. We'll have a short discussion based on three speakers, the opening remarks made by three speakers for some time. And then we'll move on to another special speakers. One is Dr. Nidhima Sumpradit, who is the AMR Focal Point Food and Drug Administration, Ministry of Public Health, Thailand. And we would hear from her about resource mobilization and pool funding mechanism to support National Action Plan implementation. Then we'll come to Kerala again, back to an Indian state. Dr. Arvind Regukumar, head of the Infectious Disease Department, Government Medical College, Thiruvananthapuram, Kerala. From Arvind, we hope to hear about the local governance initiatives in the state of Kerala to contain AMR. So with that, I will begin the session, the discussion. Just a small point to everyone. If you have any questions, please post in the Q&A box. So that we can very clearly segregate those and take some of those as time permits towards the end or sometime in between. Rajeshwari, would you like to start?
Yes, I'll do that. Thank you, Amit. I'll just quickly share the screen. Yeah. You can see, right? Yeah. Okay.
Just in the full screen mode, yes. Thank you.
Yeah. So, good afternoon, everyone. I am Rajeshwari, and I am making this presentation on behalf of the full team that has worked on the consultation that Amit talked about and the report that was developed. The idea is to take you through very quickly on what has been the key recommendations coming out of that consultation from September 2025. Like he said, more than 90 participants joined this international online deliberation from 19 African and Asian nations. About 80 interventions coming from experts from not just intergovernmental organizations, but scientific community, civil society, and industry. All streamlined and converted into a report that was shared with the Quadripartite Joint Secretariat on AMR, which is working on revising the Global Action Plan at that time. And the process is still ongoing. And this report basically covers 6 relevant issues or themes, most of which will be touched upon.
Rajeshwari, there's a comment by someone that the presentation is not seen. I hope it is seen by other colleagues there. Can anybody confirm?
Yes, we can see.
Okay. Then that might be an issue at that level only. So yeah, please carry on.
Okay. So going back, this report touches upon 6 relevant themes, which we will touch. Most of them we are going to touch today. And here, while this has been shared already formally, but we are talking about it on a public platform and taking forward the findings from the report. Just to mention, not just key recommendation, this report also covers summaries that were made by the session chairs at that time. There is a link to download, and I hope my colleague Neeraj will also put this report link for your download. Very quickly, if I move, the first theme that was discussed was on a long-term approach of moving towards sustainable food animal production systems. We started off with looking at the animal side of this One Health AMR spectrum. And some of the key points that came out from this discussion was the need to recognize smallholder, extensive or rural food animal production systems because they were sustainable, not just from the point of view of handling AMR crisis, but also being able to tackle zoonosis and climate change, while also supporting livelihood, nutrition, and biodiversity conservation. And the idea was not just to recognize, but also support and promote such systems through affordable access to veterinary care, right extension machinery, diagnostics, biosecurity, and traditional medicines. And going forward, the need for a market for these kind of smallholder producers was also something that was one of the key recommendations, because only if there is market, there is incentive and subsidies, that such kind of smallholder systems can find a way forward, albeit through credible and affordable certification systems. On the intensive food animal farming side, what came out was the need to inform that and recognize that these systems are not sustainable because they are the convergence points of AMR, pandemics, and zoonotic outbreaks, as well as climate change and environmental adverse impacts. And there is a need to invest in reducing diseases common in such systems through preventive solutions, which we are going to talk about under the next theme, and the need to recognize the immediate urgency to amend food animal rearing practices, particularly in such intensive systems, by focusing on prevention, reducing the misuse of antibiotics, and promoting sustainably grown food consumption. The second theme was on scaling up prevention aspects in food animal production systems, again from a short-term remedial approach. And one of the key points that came out was the need to first recognize what are the advantages of scaling up prevention. And it does help not only reduce antibiotic use or dependence, but it has other advantages of positively impacting public health, the ecosystem, farm productivity and profitability, and the role of participatory approach in bringing about behavior change to address gaps in knowledge about preventive solutions was also talked about. The importance of phasing out antibiotic use for mass disease prevention as well as control, which is not the real prevention, and wherein antibiotic is used as an easy and economical substitute, was highlighted. What also came out was cost-effective, process-centric preventive approaches got some attention, like good farm management, proper animal husbandry, housing, access to water, biosecurity, over and above product-centric solutions like vaccines and diagnostics, which is mostly promoted. Once we have this, the need for being able to take them to the farmers and allowing affordable access and incentives for them to adopt these. For example, vaccines for local strains, having the right cold chain infrastructure, local manufacturing, complemented with the right kind of veterinary support and incentives was also talked about. Ethno-veterinary medicines was really well accepted because these are traditional herbal preparations, quite found to be cost-effective and as successful alternatives to antibiotics, particularly in Global South. Here, I want to take a moment and highlight that just day before yesterday, we put out this report as part of our WOW activities. And this is talking about upscaling backyard and rural poultry systems in India. Basically, whatever I've been talking, this report summarizes it in the context of the Indian landscape and says how smallholder rural poultry systems is a solution not just to reduce antibiotic use, but also provide co-benefits like better livelihood, nutrition, and conserving biodiversity. It has case studies. It talks about the breeds that we have, the resilient breeds, the native and the improved breeds. And it says that such kind of a model of farming is possible and needs to be scaled up. Coming to the third theme was about water sanitation, hygiene, and waste management. And here, three important points came up. One is the need to mainstream WASH for AMR prevention, and not just mainstreaming, also linking clear government accountability, principles of human rights and equitable development, in addition to ensuring right kind of infrastructure and services for community as well as healthcare facilities was discussed. The second point was about effective waste treatment and effective management of waste to be able to prevent the environmental spread of AMR, which in the context of Global South needs to be cost-effective and less technically challenging because low and middle-income countries cannot afford to invest in resource-intensive waste management practices. And the third area was about promoting technology, innovation, and R&D for both wash and effective waste management, keeping them local, contextual, adaptable, and affordable for easy uptake, and being supported with the right kind of collaborations and partnerships and implementation research. In terms of surveillance in environment, what was important to understand that this needs to be targeted and action oriented so that it doesn't burden the low and middle income countries because they're resource intensive and instead land up jeopardizing other actions of AMR which could have been possible, and supported by the right kind of research and pilot implementation to take the right decisions towards surveillance. One important point was to clearly specify an area of intervention instead of using umbrella term environment across the revised global action plan. The next theme was about multisectoral governance and financing. Now, this is a very globally discussed topic. What came out was is very common, the need for a strong One Health governance at national, subnational, and grassroots levels. But what was important to note here was the highlight was a sector-specific governance model that was talked about, and also the need for embedding AMR into broader national health strategies, such as health policy, climate resilience, and disaster kind of frameworks. These kind of strategies were also discussed to be able to support One Health governance. Once we have these in place, the role of coordination, collaboration, and accountability among countries in the context of regional governance was also something which was highlighted, where different agencies can play a leading role, and even civil society role was discussed. Coming to financing, again, the need for dedicated AMR financing at national level, considering them as into budgets of One Health ministries, it's not new and it came up again in our discussion, but it has to be backed by the right kind of assessment of what we have. We do not have prioritization, evidence, and cost-benefit analysis. And this kind of financing can be supported with the integration or leveraging with global or national financial structures like the Global Fund or Pandemic Fund, exploring pooled funding or basket funding mechanisms and involving the private sector, and also financing from the point of view of the current landscape of exiting donors, the debt crisis affecting national budgets, and also issues of conflict, migration, and inequality. In the terms of infection prevention and control and antimicrobial use and AMR surveillance, what was important was that the One Health sector is emphasized across both IPC as well as surveillance, and the role of strong laboratory networks, legislatory support, having the right kind of data dashboards, and using advanced models like AI and genomics, as well as the private sector. The role of WASH in both IPC and surveillance, focusing on decentralized treatments, focusing on the right kind of technologies, having the right investments, was also highlighted. Like I said, even the role of IPC across One Health sectors, particularly livestock, and promoting measures like biosecurity, vaccination, and similar measures was also recognized. And the importance of a participatory approach in stewardship, I'm not going to talk much about it. We have Dr. Aravind to reflect on this, but this was also which was very well noted as part of our key recommendations. This is the sixth and the last kind of theme, which was on access and ensuring affordable access to effective antibiotics, vaccines, and diagnostics. And experts agreed that there is a need to first advocate that access to effective antibiotics is a public good, and government need to be made responsible and accountable for being able to provide equitable access to people, and solutions to address lack of access be based on equity considerations, be context specific and tailored. There is a need to encourage nations to be able to connect the language of stewardship, diagnostic, and innovation in order to improve access. And Global South can depend on measures like pool procurement, forecasting, stock out estimations, as well as post-marketing surveillance to carry this forward. The importance of local research and local manufacturing to improve affordability, access to effective antibiotics and vaccines, not just for human health, but also for animals, supported by measures like tax exemptions, subsidies, export support, compulsory licensing, having the right clinical trial framework and ecosystems is also something which was quite well recognized. I'm almost at the end. The need for financing in order to ensure access, in order to fill the emerging funding gaps, was something which was again highlighted to even in the discussion on access. Public financing of research for new drugs should be linked with access conditions, as well as encouraging collaborations, bringing the private stakeholders into loop to ensure equitable access to all these vaccines, antibiotics, and diagnostics for global South countries also saw some mention. Yeah, I think I'll stop there, and I have basically taken you through the points that came out in the report. Thank you.
Thank you very much, Rajeshwari. I think the objective was here to, so as Rajeshwari mentioned, we had shared these recommendations with the Quadripartite Joint Secretariat. We all know that the revision exercise of Global Action Plan is ongoing. Perhaps it has reached to a particular stage where the draft has been submitted. We had earlier shared these recommendations to them. While we do not know what has really happened, but we hope that the revised version, the revised draft, is adequately informed based on the Global South recommendations. Having said that, we wanted this webinar also to once again share these recommendations with the larger public and inform respective stakeholders across the global community, so that in their scenario they can take these forward. And we hope that if there are some gaps, the stakeholders who are listening to this can possibly include or modify or revise the text accordingly. So with that, thank you so much, Rajeshwari. We move to the second and very important part of this webinar, which is the panel discussion. Let me invite Dr. Evelyn Vesangula. Evelyn, over to you. And Evelyn, the structure is very sharp, very targeted, 5 minutes of opening remarks, and then we take it forward from there. Over to you. Thank you.
Thank you. Thank you very much, Amit, for this great opportunity, and also to the broader CSE for the invitation. And I'm happy to take it up from where Rajeshwari has left after the consultation that we had a few months ago in terms of contributing this to the development of the Global Action Plan. I'd like to just maybe reflect on the aspect of governance and financing as critical components in this process. Because with all the good recommendations that have gone out, and I think we have learned from the implementation of the Global Action Plan 1.0, and as we go into the 2.0 version of the Global Action Plan, and also as countries develop or review their national action plans into the next version or the next edition, one of the critical components that has continuously come up and also is an improvement in the Global Action Plan 2.4 is the aspect on governance and coordination, which I think has come out as a key lesson when we implemented the first versions of the national action plans. So looking at the importance of this governance and coordination in respect to implementation, I think, and also taking a look at it from the One Health perspective, just listening to Rajeshwari, one thing is clear, that integration is key, and not just on paper, but in action, in everyday actions. And I think that's one of the key things that we have lacked in the implementation. We have talked about One Health collaboration, One Health implementation, integration of surveillance systems, and that has been very well captured on paper. But when it comes to actual practice, we have seen a big gap in terms of implementation and even resourcing or allocation of resources and investments across the multiple sectors that are that are actually involved. So at the regional level, the place of governance plays a critical role. One, it provides an opportunity for harnessing lessons. And as we implemented the first versions of the national action plans, a lot of best practices are coming out of countries. A lot of lessons are coming out of countries, successes and failures. So in the absence of proper governance and coordination, both at a regional, a national level and a subnational level, we lose an opportunity for convening or harnessing this information to drive policy and action at the end of the day. So when we have good governance systems, we'll have an opportunity for grounded adaptation. So when there's flexibility, because information that is coming out freely flows across the country, that is from subnational level to the national level, from the national level to the regional level and from the regional level to the global level. I think that's an opportunity we cannot miss, but that can only happen if we have proper governance, we have proper coordination. The last thing I'd want to talk about on the aspect of the governance bit and the coordination is that the place of fostering collaborations and partnerships then becomes key. In the face of dwindling the finances of within this particular area, if we don't strengthen collaboration and partnerships, then we lose an opportunity for aligning priorities that have been identified at multiple levels. We lose an opportunity to align the resources that are available and also being able just to target these to areas that have high impact and high returns at the end of the day. So I think that is really, really important. And then on the other hand, when I look at the whole process of governance and coordination, I think if we have an opportunity of doing this in a proper manner that is well captured, then it also gives us an opportunity to contribute to the global agenda in a unified manner. Just like we are coming together in this particular process, we have a stronger voice from the South. And that's the whole aspect that revolves around strong governance and leadership mechanisms that enhance coordination. On the aspect of sustainable financing, I think we have learned over the last couple of years that this is not an area that has been well resourced. A lot of the investments have come in the form of projects and really not probably addressing system-specific gaps in terms of strengthening the entire system. So it is important that we look at financing going forward from a point of strengthening the entire system that we are working in. That will also encourage governments to invest. And when the government invests, we will be able to get ownership at a country level. We will have prioritized action, and we will also be able to ensure that we have continuation of these essential functions even beyond donor funding at the end of the day. And finally, domestic resources allow countries actually an opportunity to tailor their responses, to tailor their initiatives, and also to innovate, because ultimately they own the solutions and they implement these solutions within their own contexts. So what opportunities exist for sustainable financing? I think we have learned from the COVID pandemic. We saw very strong public-private partnerships. There are lessons that we can draw where demands were placed on the table and investors and industry came together and they were able to address national challenges at that point, because at that particular point, every country had to look inward because borders were closed and resources were really targeted within countries. So I think we have not fully explored public-private partnerships, especially in the way we have addressed our AMR aspects and the implementation of national action plans. And I think we now have an opportunity to really look at it in a different dimension as we go forward into implementing the second versions of national action plans or the global action plan in general. So I will stop at that point and hand over to you, and I'll be happy to come back with different reflections. Thank you very much, Amit. Over to you.
Yeah, thank you so much, Evelyn. That was very structured, very point-wise, very useful. I hope the listeners are also able to make a good note of what you mentioned, and perhaps if there are any questions, we can take those if they are mentioned in the Q&A box and if they are relevant to the speakers. Let me now come to Kate. Kate, we all know WASH is very, very important for AMR, and I know for many, many years you have been working on this issue. Over to you.
Thank you, Emma. And firstly, let me start by just commending CSE for this initiative. I think it's super useful to be getting the voices of LMICs in here and sort of correcting some of the challenges with the previous GAP, which to my mind had a very AMR specific lens on it, which tend to kind of miss some of these fundamental aspects like WASH that have wide co-benefits for health as well as being an investment for AMR. But first I wanted to just kind of define what we mean by WASH, and we could also talk about what we mean by environmental dimensions of AMR more broadly, because these terms kind of get thrown around with sometimes not the specificity of what we're talking about. But when we say WASH, we're talking about safely managed water and sanitation systems, from the sort of basic access to taps and toilets all the way through to the, in the case of sanitation, the conveyance, treatment and reuse of waste. And this is really important for AMR, of course, because those basic services prevent infections, before they happen, which reduces the need for antimicrobials or unavoidable use of antimicrobials, and also reduces the spread of distant bacteria, genes and compounds. So also, one of the other things I work on is World Toilet Day, which was actually just Wednesday this week. And sometimes people laugh when they hear World Toilet Day and think, oh, aren't we done with that? In fact, we are very, very far from done with making sure that everybody has access to a safely managed sanitation system. There's 3.4 billion people, that's nearly half of the world, lack a safely managed sanitation system. 1.4 billion don't even have basic sanitation, and of course most of these are in low and middle income countries. And then sometimes we think about this in terms of like modern sewage system. There's a whole question about what we mean by modern and high quality systems, but we think about sewers when really in sub-Saharan Africa, only 10% of people are connected to sewers. In South and Central Asia, it's only 20%, Southeast Asia, 50%. So if we want to do something seriously about AMR, we've got to be thinking about the people who don't have access and the people who are not connected to sewers. And even those that are connected to sewers, only about 55% of that wastewater is treated to at least a secondary level. The numbers in healthcare facilities are equally shocking, so our ability to prevent infections in healthcare facilities is, of course, hugely undermined when we have 3 billion people in healthcare facilities who don't have at least basic sanitation. So my argument really is for bringing everybody up to at least that basic level. And we know that those technologies have similar log reductions for resistant bacteria as they do for other forms of bacteria. So this alone, just getting everybody up to that basic level, is a huge co-benefit for AMR. And we have to keep our eye on that and not get too distracted by high-tech solutions on wastewater treatment plants that are effectively reaching a small proportion of the population. So, and I think, it's easy to forget all of this when all of us are sitting in kind of relatively nice places. We have access to good sanitation. And so I think AMR is a really good way to take what is quite a localized issue for people who lack basic sanitation to be really clear that it's a global issue, because AMR can get on a plane, it can spread around communities and far more broadly than the localized issue of sanitation. So I think it's really good that we're starting to see some of these things emerging, these strategic shifts and guiding principles within the GAP, kind of addressing these issues of human rights, equity and basic services. Would like to see a really continued emphasis on that. I think the WASH and healthcare facilities part is strong and kind of obvious from a health perspective. Sometimes the WASH and communities bit is a bit lost, so I think we need to keep pointing our AMR colleagues to WASH and communities, not just in healthcare facilities. I think one of the reasons that kind of gets neglected, because there's a fear that, that huge cost of getting WASH services to everybody might fall on the health sector or the AMR agenda, when in fact there's a whole lot of different entities that fund into that, and the role of the AMR national action plans is to kind of provide that powerful lever for greater prioritisation investment in water and sanitation services. I don't want to sort of go on for too long, but just kind of transitioning to management of wastewater, we see a lot of drivers now in the circular economy and in climate mitigation and adaptation to look at reuse of wastewater and sludge. There's a really missing component there that worries me a bit. We're not talking enough about what do we mean by safe reuse, and particularly what is safe reuse for AMR. And from WHO's perspective, one of my priorities I really want to get moving on is updating our global standards for safe use of wastewater, so that we have a global benchmark of what is safe while we're promoting the circular economy. Finally, just to touch on antimicrobial waste, which is often linked into the WASH agenda, management of manufacturing wastewater and also unused medicines. So the manufacturing wastewater is one place where we can really, and there is a very strong case to invest in the tech and regulation that's needed to make sure manufacturing is safe, while also bringing everybody up to a basic level of safely managed sanitation. And similarly for unused medicines, there's a very broad healthcare waste management agenda, and we need to make sure that the safe management of antimicrobials is well covered within that healthcare waste management agenda. I'll just close by saying I've talked very much about sort of WASH services for humans and wastewater from manufacturing. And hopefully someone else will touch on this, but not forgetting that a huge amount of wastewater laden with antimicrobials actually comes from the agricultural sector, and the numbers for that is completely is unestimated, in fact. So we need to, while working on these kind of human wastewater and sanitation and WASH issues, also be making sure that the agricultural sector is doing their part to manage emissions to environment through sort of agri-wash, if we adopt that term. I will stop there and perhaps can circle back to some of the surveillance and monitoring issues in the Q&A. Thank you.
Thank you very much, Kate. I think you have highlighted some very fundamental issues. Structurally, I mean, I can very well relate to some of these. Many of our colleagues and participants can also relate to the others. But I will not open up for any questions right now. I'll move to the next speaker, so that we take, in the interest of time, we take some questions together. So thank you, Kate. Now, moving on to Dr. Vandana Roy. Dr. Roy, another very important issue of access. Over to you, please.
Thank you, Amit. Thank you, Rajeshwari and CSC, for your invitation and organizing this extremely important webinar. I'll come straight to the point. So the topic is access to antibiotics. Now, antibiotics are a subset of medicines, and there is a problem of access to medicines globally in all groups of drugs. About 2 billion people lack access to essential medicines, which is nearly 30% of people. And health spending on medicines may account for 20 to 60%. Health spending may account. Spending on medicines may be 20 to 60% of the total health spending. And in countries where there is no insurance and other support systems, out-of-pocket expenditure ranging from 40 to even 90% may account for expenditure on medicine. So many people get into debt, abject poverty in trying to procure medicines. That's in general. Now we come to the problem of antimicrobials and their access. It's a specific group with its own individual problems, because access has three components, availability of medicines, affordability, and their appropriate and rational use. So I'm just going to discuss this. There are two areas, Amit, which come under this. One is access of existing medicines and access to new medicines. I'm going to focus on access to existing medicines. Now, there are a lot of antimicrobials available in the WHO's EML itself. You have over 170 antimicrobial organisms, and in the antibiotics or antibacterials, there are more than 40. So that's a huge number. How do we ensure access to the groups which are already there? The easiest way, a very possible way, and in which WHO has already been working for the last 3 or 4 decades now, is the essential medicine concept. We need to push the concept of essential medicines into national medicine policies. It's already there, but they're not working. So essential medicine lists under national medicine policies need to be pushed need to be encouraged and implemented in a in a much more bigger way. And the section on antimicrobials needs to be, country specific, then maybe region specific, country specific, state, district, village, community health center, PHC specific. So I'm talking at the macro level. Countries need to have national medicine policies based on the essential medicine concept, focus on antimicrobials, characterize them, in the access, watch, reserve category based on their regional antimicrobial sensitivity data. WHO has done it, but we use that as a sample, but we develop our own. And many countries now have, they've built up their diagnostic laboratories, and they're doing antimicrobial surveillance. So that data right now is just lying in laboratories. It's not getting linked to use. It's not reaching the antimicrobial use data, which is being picked up, it's not linked with the antimicrobial resistance surveillance data. So we need countries to start using their surveillance data to develop their national list and their local. And it begins at the macro level, and it needs to go down till the PHC level. It's not difficult. It's doable. You need to divide a country like India with 28 states and 780, and I think about 8 UTs. We can easily develop national, state level policies, state level sensitivity data, which is too broad still, and then narrow down, tertiary care hospital, secondary, district. It is not difficult. It's a very doable thing. And this would be in my opinion, one of the easiest ways of using what we have, improving access to what we have, saving what we have for a much longer duration than what is happening. So that's about macro and micro. Another thing which needs to be put in policy is all healthcare facilities have to have drugs and therapeutics committees and antimicrobial stewardship programs, not only on paper. Right now, many health facilities in many countries do not have it even on paper. And at grassroots level, they need to be working together. Use or prescribing of antimicrobials, H1 schedule is there, but it needs to be a working schedule. It needs to be implemented. We could do it for narcotics. I'm not saying, so narcotic is to prevent abuse. So this is to prevent deaths. Another way of restricting or helping increasing awareness to help prevent wasteful use is by starting to have AMR as a cause of, diagnostic criteria of death. So we collect mortality data in hospitals. AMR is never taken as a cause. So if we started recording that patient, we did not have antibiotics to save this patient because of antimicrobial resistance, it would get taken up by the healthcare providers. I'm talking about human healthcare, that aspect more, Amit. So this is about how can we use what we have better from macro to micro level. And regarding and of course, I said you need to the prescription. How do we regulate it? Something has to become a draconian measure has to take place. H1 schedule is not enough. We could do it for narcotics. What can we do for? I'm talking about, this is India specific, but I'm sure other countries have their own rules. How can we prevent sales in a country or in countries where it's so easy to get despite legal provisions? So we need to think about that. Then regarding giving a diagnostic criteria, a criteria. It's a diagnosis. AMR is a disease criteria. It needs to come somewhere in ICD-10. I don't think it's there right now. So we start recording it. AMR as a cause of death. Right now, Lancet papers, all studies we are extrapolating that to 2050, so many people would have died, but we need to start doing it now, making it mandatory that in our mortality meetings in the hospitals, we discuss it. Now, so regarding access to new medicines, well, we have policies. This is much more difficult. You have to have a policy, you have to do R&D, you have to look at off-label uses of drugs. AI needs to be used in a bigger way. I think they're already doing it for docking studies to see which are the off-label drugs, which are the existing drugs which can be used for antimicrobial purposes. And can we coin, since AMR is resulting in organisms which are going scot-free, so we have diseases caused by organisms where medicines are not acting. Can we give them a new diagnosis? Can we classify them under something like orphan drug disease organism? I mean, I was just thinking, because AMR is a big problem. ICUs, medical wards, it's a big problem, and we do not have antibiotics. 60% resistance, 70% resistance. Very few reserve antibiotics which are being used in the form in which access antibiotics are used in tertiary care hospitals. Can we give a designation to these organisms as orphan drug organisms or something, just to highlight a problem, an impending problem? So just some questions, ICD-10, can we get it in as a cause of death, as a diagnosis, orphan drug disease organism? Can we use our EML national drug policies and promote rational, promote EMLs with a specific category of, the antimicrobial section? There's we need to do more on making what is already available accessible, Amit. Newer drugs is okay, but can we save and use what we have better? That's
Thank you so much. Thank you so much, Dr. Roy. I think in the interest of time, I will basically move to the next set of speakers straight away, and then take the questions in the last 10 to 15 minutes that we have. So, Dr. Nithima, may I move on to you quickly and try and understand your perspective from Thailand, Dr. Nithima?
Yes, thank you.
Over
May
to you.
I share the slide?
Okay.
Okay. Hope you see the slide already.
Yeah, but please make sure that this is 5-7 minutes only, not more than that.
Okay. Yes.
Thank you.
My topic is about the resource mobilization and the pool funding mechanism to support the NAP implementation. Like we already know that there are many countries that already have the GAP-AMR, but have limited resources for the implementation. And this is like the common source of the resources that are available to each country, like the government budget, funding from donors, or the resource sharing. And my focus will be on the pool funding mechanism to share experience from Thailand. This picture is about the NAP in Thailand, that we set the goal over here, and we set the strategy to achieve this goal, to moving the GAP-AMR forward. We have like a two mechanism. The first mechanism we call the national governance mechanism, which is funded by the government budget or donor for support some project or resource sharing. This is an implementation part, but we also have another mechanism we call the scientific platform to support the implementation. This scientific platform is to generate evidence to support the NAP implementation and develop the M&E monitoring and evaluation system and strengthening capacity. This platform, scientific platform, is funded by the pool funding mechanism between the Royal Thai government and the WHO under the WHO Country Collaboration Strategy Program. Just give you the background about how the pool funding have been implemented in Thailand. Actually, in Thailand, we implement the WHO Country Collaboration Strategy since 2002. And it's like a 5 years. Typical in the past is like a more than 100 projects each round, which is very a lot. And then there was the WHO resolution asking the WHO to manage the resource better in terms of to use the social and intellectual capital of the organization to leverage additional resource to support the national priority program. So in 2017, Thailand initiated a strategic, innovative and unique approach for the partnership, resource sharing among Thai partners and WHO via the pool funding mechanism. We call it CCS program 2017 to 2021. And the aim is to promote the country's ownership, and the WHO serve as a catalyst to broader collaboration across sectors, maximizing whole social and intellectual capital. The CCS program consists of 5 areas. AMR is one of them. And these are the list of funder. You can see the WHO is one, and there are like 5 Thai agency also provide the funding support for this program as well. For the CCS AMR program 2017-2021, we received the total fund is like around $1 million, and WHO invest 1/3, and 2/3 we receive funding from the 4 Thai agency name listed over here. And the pool fund is earmarked for support the GAP-AMR, not for the specific interest of agencies. All funding agencies who participate in this CCS program must agree on the goal, target, and the key activity of the CCS AMR program. They need to accept the same technical and financial report, because we not generate the different report to each agency. We use the same set of report submit to all agencies. And third, they must share on an equal basis collective, that they can share the collective ownership of the program success, progress, and challenge. And this is just an example of activities that under the pool funding mechanism, we have the report, evidence, and also the M&E program. And this is also some kind of activity, for example, National Forum and WOW that we Thailand Antimicrobial Awareness Week. So in conclusion, we found that a pool funding mechanism provide a good return of investment, because whether or not agency contribute more or less, or partners share collective ownership of the program inputs. In contrast, if they work alone, they would do a very small piece of work on a limited impact work. And in terms of sustainability, the project initiated under the pool funding mechanism were commonly adopted and have been continually implemented by the relevant agency afterward. For example, the Thailand surveillance of antimicrobial consumption that generate under the CCS-AMR has been adopted as a routine at the FDA, and the integrated AMR management in hospital adopted by the Department of Medical Services, and integrated AMR surveillance under the One Health approach also was adopted as a routine at the Department of Medical Science. However, there are some challenges for this approach, because they need a managerial process a lot. For example, we need to arrange for the funding dialogue. We need to identify the key area and pinpoint the qualified program manager, because these factors are crucial to ensure the program success. That concludes my presentation. Thank you.
Thank you so much, Dr. Nidima. You can just remove the slides, please. Thank you. So we come back to you while we address the questions. So the last speaker for today is Dr. Arvind Regukumar. Dr. Arvind, over to you.
Also, I'd like to thank CSC, especially Amit and Rajeshri, for this opportunity. Greetings from Kerala. So my task is to take you through the role of local self-governments in the implementation of the state action plan. Way back in 2018, when the state launched. Actually, the first state launched the state level action plan, that is CARSA. So it was basically like, we had a nodal center, that is the microbiology department at my institute. And our target was actually to reach the masses. So basically the message of AMR. So, if it is being, it can be led by a microbiologist or a pharmacologist or an ID person, but, we will never reach the masses. So then when we went through the 6 strategic priorities in the national action plan or the global action plan, that is the same in the state action plan. The first is actually creating awareness among all sectors of the society. That is, the farmers, the civil society, doctors, and all those stuff. So in the lab, so as a microbiologist or an ID person cannot reach out to the masses. So the best thing is that we need to have something which resonates with the public. So in 2019, we came out with the slogan that is Antibiotic Literate Kerala concept. So antibiotic literacy means that, the 10 things that everyone in Kerala should know about the right use of antibiotics. So this is a One Health based concept, because farmers also need to be aware of certain the messages like that. The next thing is that it is very easy to say that you want to make everyone in Kerala literate about the right use of antibiotics in a One Health perspective. How are you going to achieve that? Therein comes the financial crunches. We may not be having a separate budget line for the AMR sort of thing. Then we realize that in a lot of things that we talk about AMR, that is in a priority, one is awareness, understanding, second is actually this AMR surveillance, third is IPC, and fourth is antimicrobial stewardship. This IPC and antimicrobial stewardship actually, it's a part of quality. Quality is having actually a separate funding line is there for quality. And where all these activities converge is actually at the local self-government level. Because in our local self-governments, there will be a hospital and there will be a veterinary hospital also. So actually, real One Health is being practiced at the local self-government level. So in order to actually, to get this message across to the public, that is basically the concept of participatory antimicrobial stewardship that WHO came out about in 2023 October, that we actually started practicing from 2019 in our state. In order to do this participatory stewardship, we established district level AMR committees. So we have these 14 districts, so 14 AMR committees were established. And at that time, we had 190 health blocks. Then we came out with this, the block level AMR committees. So a government order regarding the SOP, regarding what the district AMR committee should do, the monitoring and evaluation framework, what the block AMR committee should do, etc., were actually released as government orders. So by that, from one nodal officer, that is a microbiology head, we had nodal officers in 14 districts as well as 190 blocks. So basically, we have 190 plus 14 AMR champions at the ground level. Then actually we need to create awareness among all the doctors. Because at the PHC level, FHC level, we may not be having a microbiologist. For that, we came out with the concept about antibiotic smart hospitals at the primary care level, secondary care level, and tertiary care level. So at the primary care level, the antibiotic smart hospital means that a hospital which satisfies 10 criteria, which has been published as a government order, will be declared as an antibiotic smart hospital, and which we were able to declare 2 of those. Of the 10 criteria, 2 are actually very difficult to achieve. The other criteria resonates with, the strategic priority 1, 2, 3, as well as 4. The difficulty to achieve is that we said in primary care, more than 95% of antibiotic use should be from the access category. So basically, if you look at the WHO, the targets or global action plan targets, all these targets are reflected in the criteria we set for the antibiotic smart hospitals at the primary, secondary, and tertiary level. So when we came out with this antibiotic smart hospital initiative, the local self-governments, what we call as panchayat here, they took full ownership. Because one PHC is declared as antibiotic smart, it is a great pride for the panchayat. Because the funding for running this hospital is partly given by the local self-government. So they started mobilizing their fund for all these activities, for making these hospitals in the locality antibiotic smart. So once we actually energize all these hospitals in the state to try to become antibiotic smart, then we actually changed the goalpost. We said that the next priority is to make antibiotic literate panchayats. That is, you are having an FHC, and around this FHC, you want to make that local self-government area or panchayat also antibiotic literate. How will you do that? So basically, you have a criteria to become antibiotic smart. So that is just one criteria to become an antibiotic literate panchayat. Next will be to identify all the hotspots for AMR in the panchayat area or the local self-government area. Like, it will vary from local self-government to local self-government. Some areas you will be having this poultry industry. or say you'll be having this butcheries and all other areas will be having fisheries, aquaculture, like that. So they need to map all the hotspots, which includes the schools as well, because the children are our future generation. So we need to train them in AMR in a continuous fashion. So all the responsibility for this rests on the doctor in that this antibiotic smart hospital. So and then we came out with this criteria for this antibiotic literate panchayat, so that the entire the momentum is actually driven by the activities at the ground level. So would have seen the activities which happened in Kerala during the World Antimicrobial Awareness Week in 2022, 23, 24. In 2024, we actually covered all the blocks. 2025 activities are going on, and our aim is to declare Kerala as an antibiotic literate society by January 2026. It is a very difficult task because no other place in the world has actually thought about declaring an area as antibiotic literate. So we actually came out with 10 criteria. We want everyone to know 10 cardinal messages, One Health messages with regard to antimicrobial resistance. So we have come out with a slogan, My Kerala, Antibiotic Literate Kerala. So this is actually being aired through all this media and all those things. And we have a mascot like a capsule is speaking to the public. So over the next 1.5 months, we are going for the mopping up campaign. Mopping up campaign means through radio jingles, etc. We are going to hit everyone hard with these 10 messages. And then actually an external agency is going to see whether, the target is achieved, whether, everyone in Kerala is aware of these 10 points. We may fail, but this is an attempt, right? So the attempt is very, very important. So that means that everyone in Kerala is taking ownership. So one spin-off of this strategy is that a couple of years back, we were able to ban the OTC sale of antibiotics. It's not even Schedule H1. It is banning the OTC sale of antibiotics in Kerala. And this led to around 20-25% decrease in the sale of antibiotics to tune of around 1,000 crore. So the people did not make any problem against this because of the awareness created as part of this antibiotic literate panchayat. So if you want to make any regulations work, the thing is the awareness has to be there. Only then the public will be with you. Actually, India has enough and more routes. The problem is implementation. We want to implement them. The ownership has to be taken up by the public. So if that is to happen, the focus has to be on strategic priority 1, that is creating awareness. So in Kerala, our strength is decentralized approach to tackling anything. That's the reason why actually we went about, instead of having a top-down approach, we focus on the local self-governments. And in that way, the funding also is easy because LSDDs will fund all these activities. So that is from my side. And another thing is that, this is being raised in assembly also. When we actually make certain hospitals as antibiotic smart, in the assembly session, the other MLAs are asking why you have declared only a few hospitals as antibiotic smart. Why don't you want to make all the hospitals antibiotic smart? Are you focusing only on certain LSDDs? Why don't you want to make entire Kerala as antibiotic literate like that? So we want this communication to go on. We want everyone to ask questions. Then AMR will actually come to the forefront, and all this funding and all those things will be easy.
Yeah.
So thank you very much for the opportunity.
Yeah. Dr. Raghukumar, so very, I would say, excited and pleased to hear you. I think the idea of having you here today was to let everyone know what Kerala is doing and how effective local governance can really help the cause. And you have very, very structurally, beautifully explained all the initiatives. And I know personally that yes, Kerala is an exception in India. But I also know that there's a lot of learning that not just in Indian states, but also in the Africa, that can be that can be drawn from Kerala. And that is why I would just quickly like to bring in Evelyn here. Evelyn, do you think something like this will help address the key question that you mentioned? I would request all panelists to come to open up their videos if they can. We can just have a 10-minute of discussion. Yeah, thank you so much. So Evelyn, when you were speaking, I thought how to go about it. You basically raised the question on how to move from paper to the ground. And here I hear from Arvind, this is so clearly done in the ground. And he also now talks about the impact, involvement of politicians in the assembly. He also now talks about the importance of awareness, how awareness has helped in implementing a regulation which is otherwise very difficult to implement in our country, which is banning antibiotic sale. So I just want to bring in, we have less time. I just want to bring in Evelyn here to for a very brief reflection on if there's something that she thinks can Kerala be helpful to understand to take forward something in Africa, or maybe something you have from your side that you now think after hearing him is a possibility in African geography?
Yeah. Thank you very much, Amit, and thank you, Dr. Arvind, for your great submission and sharing your best practice. Actually, just this week, we met with about 10 countries, and we were trying to define a learning agenda which is structured, because we realized each of the countries has a very rich experience. They have best practices, but we did not have a structured way of supporting countries to learn from one another. And I think, like what you've said, whatever is working in Kerala can also work in parts of Tanzania or parts of Zimbabwe or parts of Kenya. And I think ensuring that we have collaborations that are structured and not one-off is something that we can actually be able to pursue and learn from one another and take on solutions that have actually provided evidence in one part of the world in another. So I think, Amit, it's possible to take that, but I think what that needs is a clear structure. How do we then structure learning experiences, south to south learning experiences? What platforms are available? For example, CSC is a platform that we can use because you have the advantage of looking at different countries. We also have a learning platform. And if we come together, we are able to bring together teams and countries, and knowledge can actually be able to flow freely, and interventions and opportunities can also be able to be adapted within similar contexts. And I agree with you in terms of awareness and the involvement of parliamentarians or the politicians. We are also exploring a similar mechanism in Africa. We just recently also got into an MOU with about 12 countries in the Eastern and Southern Africa. And the parliamentarians in those countries have an intergovernmental forum, which we are now beginning to have conversations around AMR just to build awareness. If there's such a forum, for example, in Asia, can we be able to learn across the different regions? There are lessons that can be shared so that we are able to leverage on each other's strengths and successes at the end of the day. So as I wind up, I think for me, what is needed is a platform that will be structured, and a platform that will connect different countries and different regions to enable us to learn, just like I heard from also Nithima, and I felt I need to take people to learn from what Nithima is doing in terms of financing. And now there's a good stewardship example again. So I think for me, it's that platform that will be able to bring people together. Thank you. Over to you, Amit.
Yeah, thank you, Evelyn. We at CSC over the years have also realized the importance of such platforms. We are trying our bit, but we know it is not enough. A lot needs to be done. And this kind of cross-learning is very, very critical. We need to help each other. We need to learn from each other. And we need to also learn what not to do. Dr. Roy, I just want to bring in you here. Your reflections on what Arvind or Evelyn has said, or anything that you wish to add now after hearing others.
Uh, well, Kerala always stands out in terms of what, in education and health, including their essential medicine list and policy. So antimicrobials, actually what Kerala has achieved is not surprising, because when Kerala sets its mind going, they do it always. They always achieve. So yes, we need platforms. You want me to comment on both? We need learning platforms. We need to share our best practices uh, to improve. And Amit, there is already a lot of good shared practices, a lot of good material already available. My take is we need to move ahead from where we are, from meetings and recommendations and
Yeah,
plans which look so good on paper, GAP and then NAP. We need to get into action mode, into a mission
yeah,
mode, and not a plan, a program maybe.
yeah,
We need a governance structure at the national level, intersectorial governing council with then states, and then right from top to bottom accountability, a specific group. Maybe you have the PM chairing it, the head of institutes in all the countries. We need it. We call it a silent pandemic. I mean, we went into mission mode when COVID happened. We did a lot. We achieved a lot. Can we not do it? I mean, this is a silent, slow pandemic killing people, and we are not even accounting for it. So we need to act now, Amit. There is enough of learning. We need to get into mission mode,
Yeah.
program mode. That's it.
Thank you. Thank you. Dr. Arvind, very briefly, you mentioned about a point that the funding is happening by the local self-government. And I heard very well Evelyn basically saying that funding is where everything gets stuck. Uh, how you think local governments are funding? I mean, the message I take is that you actually do not need too much funding for a lot to be done. Is that the correct message?
Actually, that's the correct message because because that means when I attend the national level meetings, the feedback I get from many states is that we need a separate budget line for this state AMR program. So for around 4 to 5 years, Kerala was a zero budget program. Okay, so majority of the things were achieved by a zero budget. Then actually, since we were achieving a lot, then we had this World Bank funding, and 2021 this One Health. We started the One Health program. So in 4 districts, we are having World Bank funding for this One Health. One Health, there are two arms. One is zoonotic disease, and the second is AMR. Since AMR has been going on in the state from 2017 onwards, so One Health also AMR took the lead. So it's AMR plus zoonotic disease. So 4 districts, you are getting funding from World Bank. So we did not start with funding. So what we did was the strategic priority one is actually awareness creation. Second is the surveillance. Surveillance, we are having the funding from NCDC because we are part of the NARSNet. And we probably have the largest surveillance network in the country as far as medical colleges and etc. are concerned. So that part is taken care of. Third is IPC, and fourth is stewardship, right? IPC and stewardship are part of this quality. So NHM has this quality division. So if you want to increase the IPC standards in a hospital, why do you want funding from this AMR budget? So it is your responsibility. You're supposed to do that. Why do you want funding from AMR? So you are
Okay.
supposed to improve the quality in your hospital. Antimicrobial stewardship is part of quality only. So this NABH accreditation, KAIKALP accreditation, all these things, we are supposed to have these budget lines, right? So we cannot insist that you should have this, funding coming from the AMR program, nothing like that. So we actually latch onto that. The last aspect is the LSDD funding. LSDD means, here it is totally decentralized. So the primary care centers, the FHCs, UHCs are actually, the ownership is with the LSDD. So if we actually tweak the priorities a bit, every day some activity is going on in the PHC, like malaria day, TB day. So what they did is, along with malaria, they will talk about AMR. Along with this TB, they will talk about AMR. You know that the
Yeah.
funding for TB program, so they get enough and more funding. So why can't they bring two more these things for AMR? So it is actually the shrewd utilization of your available resources. And
Okay.
once we got going, then funding never became a problem.
Great,
So
great,
that is
great. Thank you
how
so
it
much.
works.
Dr. Arvind, I'll just stop you there. Really sorry, but very, very interesting points. You're basically saying it can be done. You need to apply. You need to apply yourself. Kate, I'll come back to you at the last. Let me just quickly move to Nitima. Nitima, I'm basically moving from the funding at the local level to the pooled funding thing at the national level, Nitima. Very interesting example, very interesting case from Thailand. Any reflections from your side? Because we also don't want to believe that you don't need funds. Funding is required, but we do want to also communicate that perhaps we need to be careful and smart enough to be able to do things which can be done with less funding, or you can kick off with them and then gradually improve on them once you have more funding. Maybe something like that. Yes, Dr. Nitima, please go ahead. Very briefly.
I think like when we start implementing the NAP-AMR, we need the funding, of course, like the seed fund to get start of the system. Once the system, like the surveillance system, has been established, we can do the maintenance later, and the maintenance part will use the less resources. And the second point is about the resources. Funding is important, but human resource who are operate or implementing the NAP-AMR also very important as well. If we have issue about the the manpower shortage, that would be the serious issue, because although you have like a lot of funding, but you cannot find the staff to work with you and the secure staff to be work with you. That is the pain point as well. Thank you.
Okay, thank you so much. Kate, over to you. Last few minutes. I just want to say that I mean, you've raised some very important points of core benefits of maybe perhaps over dependence on the modern sewage systems and high-tech solutions, perhaps missing the very basic ones that may have much more higher return on investments. One single question I have for you, and what do you think at the global level? For us, you are someone who is working in an intergovernmental organization, having a good visibility of what is happening at the global level. You're part of that. How do you think the WASH has really been able to integrate so far in the AMR work, and what needs to be done?
Thank you. Yeah, well, yes. I mean, this could be a sort of a glass half full, glass half empty kind of thing, but I think we've made a lot of progress in the last sort of 5 years, especially. I think, you know, trying to get past this, things need to be really AMR specific. We can't do WASH unless we're doing the little additional bit that makes it AMR related WASH. So things like the people-centered framework that has come out recently has been really useful. That's the WASH is really well embedded in there. You see it very well embedded in the UNGA political declaration across there. We're sort of backing that up with high quality guidance and programmatic work, whether that's on healthcare waste management, WASH and healthcare facilities, working with water and sanitation regulators or the finance ministries and so forth. But I think this kind of question we've been circling around with sort of governance and funding and coordination is one we face in a lot of areas. So we don't just work with AMR, we work with the neglected tropical diseases team, we work with the integrated surveillance teams. There's a lot of different, or IPC, lots of different areas that we collaborate on. And I think some of the lessons from that apply very much here as well, right? So you kind of have to have this network structure where rather than one entity trying to own the issue, you have it embedded in lots and lots of different things in which those responsible entities do, fund their own area of work. And we talked about, malaria or TB or WASH is one of those things, but then AMR gets integrated into that work as part of their structured funding, part of their structured governance. But that coordination and integration has a cost in terms of time and people and coordination, and you need to put the funding there because it doesn't happen by magic, right? It takes time to wrangle all of these relationships and get people coordinated. But I would just say finally, one of the things that we're having quite a lot of success on in terms of governance is working through regulators. Not in a kind of heavy-handed regulation kind of way, but being clear that regulators are a very powerful kind of entity and a relatively small number of people that you can access globally, and with the kind of right information about what to regulate, how to regulate it, how to enforce or provide incentives, we can use them as a kind of a way of taking these ideas that exist in action plans or recommendations and reports to actually things that are embedded in national systems and governance structures. So I think they're a really important stakeholder across all of the different areas where we want to make progress on AMR, to understand the regulator and empower them to regulate sensibly for this issue. I'll stop there.
Okay, so thank you so much, Kate. I think the time is up. This was a 75-minute webinar, and we do not want to not beyond 2 more minutes. So I just want to say there are some clear messages that we heard today from different stakeholders from different parts of the world. I don't want to summarize them, but clearly very broad messages. Some bit is happening and a lot needs to be done. It could be glass empty, glass full kind of a scenario. Clearly, there are some good examples of local governance, which can, from a bottoms-up approach, can perhaps feed into the global governance or the regional governance, if at all, if not the global governance. Clearly, there are examples at the national level of pool funding. Some fundamental questions raised by Kate, I personally feel those are very, very pertinent because prevention is where you need to focus. I also agree with Dr. Roy, need to move now from paper to the ground, act, act, act. So it's like prevent, 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 but it's also about act, act, act. The good part is there's a lot that can be done at the local level. Perhaps the focus should be more on the local governance. Perhaps the focus should be more on approaches which are not just prevention, but also have co-benefits, as WASH is one very clear example. Huge, strong co-benefits you have. When you invest in WASH, you clearly save a lot of not just money, but a lot of lives. So, so with that, I think I should be finishing this, wrapping this up, and with a big thank you from the CSE family to all of you. Uh, uh, I, all I can say is that we are working on this together. We have been working on this, and we will continue to work on this for many more years. I hope so, but also with a desire that we don't really need to work on this issue for that long, because that would mean that the issue is not addressed. We want the issue to be addressed. There are a couple of questions which we haven't really answered from the Q&A. My colleagues will try their best to reach out to them and answer if that is possible. So with that, thank you very much. Good afternoon, good morning, good evening, good night to all of you from where you are, from wherever you are.